This conference will now be recorded.
Yeah, so just be aware of that. Okay, so to start with the introductions, first up, we're delighted to have Dr. Jeffery Kelly speaking today. He's the Lita Annenberg Hazen Professor of Chemistry at Scripps Research in Southern California. Dr. Kelly kind of most notably discovered tafamidis, which is the first regulatory agency approved drug that slows the progression of transthyretin amyloidosis. Currently, his lab is focused on research to understand the principles of protein folding and to comprehend the basis of misfolding and aggregation diseases, with the aim to develop novel therapeutic strategies, i.e. first-in-class drugs that modulate protein homeostasis that would slow the progression of protein misfolding. Dr. Kelly has published over 350 scientific papers. He has placed 5 trainees or tenure track academic positions and 60 former co-workers in biotechnology and pharmaceutical positions. He has multiple awards. Most notably, he was elected to the American Academy of Arts and Sciences in 2016. After Dr. Kelly, we'll be hearing from a mentee of Dr. Prem Soman. So to introduce Dr. Soman, he is an associate professor at the University of Pittsburgh. Dr. Soman's research focuses on the use of radionucleotide-based imaging techniques in cardiac diseases, particularly heart failure. Current interests include cardiac amyloidosis. He is also well known for his work on the use of myocardial SPECT imaging for the left ventricular desynchrony assessment, an area in which his group has contributed seminal work with prior mentees winning the ASNC Young Investigator Awards over the years. As I mentioned, Dr. Soman is a cardiologist at the University of Pittsburgh Medical Center Presbyterian Hospital. He's the director of the Nuclear Cardiac Lab there, the Advanced Cardiovascular Imaging Fellowship, and of their Cardiac Amyloidosis Program. Most notably, Dr. Soman was awarded the Herman Blumgart Award for Outstanding Achievement and Service to Nuclear Cardiology by the Society of Nuclear Medicine and Molecular Imaging in 2016. And the speaker from his lab will be Dr. Syed Bukhari. So Dr. Syed Bukhari is excitingly in his first year of a 2-year dedicated cardiac amyloidosis fellowship under Soman. I've had a quick preview of Dr. Bukhari's slides, and I can say this is going to be a very interesting talk and slightly different from what we're usually used to hearing at nuclear imaging talks. So I'm pretty excited about this. And finally, our discussant for this will be Dr. Ed Miller, who is an associate professor of medicine, radiology and biomedical imaging at Yale University School of Medicine. He's also the director of nuclear cardiology at Yale New Haven Hospital and Health System, as well as the director of cardiovascular medicine fellowship program. His academic interest involves basic translational and clinical nuclear cardiology investigations. He is the director of a nuclear cardiology core lab for international multi-center cardiac imaging trials and investigations in population health and the imaging of cardiac amyloidosis. His clinical practice centers around the evaluation and treatment of patients with infiltrative heart disease, both amyloidosis and sarcoidosis, including developing novel uses for nuclear cardiology imaging in these conditions. Dr. Miller has multiple research awards, including NIH and industry-funded focused on cardiac metabolism, and a translational institutional award to develop new clinical cardiometabolic imaging methods. So I think we can all agree this will be a very exciting panel to listen to today. And just to remind you, we'll have another session next week where the focus will be cardiovascular inflammation. And we'll be hearing from speakers from Harvard Medical School. And then the following week, the topic will be coronary microvascular dysfunction. Reminder before we get started of upcoming deadlines for ASNC. You can see that the Young Investigator Award deadline is coming up this month, as well as abstract submission for the annual meeting. So keep those in mind. Go to asnc.org for further information. So without any further delay, I'll let Dr. Kelly get started.
Well, good morning, everyone. It's a real privilege to address this distinguished group. I thought what I'd do today is to introduce what we know about the transthyretin amyloid diseases, especially from the perspective of what we know and we don't know. And in the course of that, I'll tell you how we discovered tafamidis. So when I started working on the transthyretin amyloid diseases in, I guess, 1990, a long time ago, the hypothesis was that these were infiltrative diseases. That is, that the presence of amyloid compromised the tissue, and that was the main cause of the pathology. I don't think there's any question about whether amyloid in the heart is a good thing. It is not. But I think it's quite interesting now that we have multiple therapies that seem to afford the patient multiple benefits. And it's arguable that that happens without rapid clearance of amyloid. And we'll talk more about that later. So I think about the transthyretin amyloid diseases as cell non-autonomous or in-trans gain of proteotoxicity diseases. So let me explain. So the liver secretes transthyretin into the bloodstream as a tetramer. And tetramer dissociation, misfolding, and aggregation that I'll have more to say about later, that process seems to destroy tissues that are post-mitotic and don't easily regenerate, like the nervous systems and the heart. Now, interestingly, those tissues don't even make transthyretin. So it's an outside-in type of toxicity mechanism. And at least in the familial cases, these diseases are autosomal dominant. Of course, we shouldn't forget that the most prominent transthyretin amyloid disease involves aggregation of wild-type transthyretin, which we and others are trying to figure out, why does the wild-type protein aggregate in 10% of predominantly older males? Something that's, I think, a fundamental question. The tissue tropism of these diseases is really important for you folks as clinicians and scientists to think about. So the wild-type, the aggregation of the wild-type transthyretin protein presents as a principal cardiomyopathy with significant autonomic nervous system dysfunction. Whereas if you have, say, the VAL30 MET mutation, early onset, that's a principal polyneuropathy. But in some countries like Sweden, for example, that mutation typically confers a mixed phenotype of cardiomyopathy and polyneuropathy. And instead of having age of onset around 30 years, which is the case in, say, Portugal, in Sweden, it's typically much later than that, say 50 or later. Now, in addition to polyneuropathy and cardiomyopathy, as physicians, now that we have effective drugs, you're also going to have to worry about ocular pathology and CNS pathology, and I'll get more back to that later. So there's very strong genetic evidence for the amyloid hypothesis. Now, it's important that we understand what I mean by the amyloid hypothesis. We define that as the process of transthyretin aggregation as causing the disease. It doesn't say specifically that the cross beta sheet amyloid fibrils cause the disease. Okay. Now, what's the genetic evidence supporting the concept that aggregation is the main driver of these pathologies? Largely, it was discovered by Teresa Callejo, and she noticed that in some of her large VAL30 MET polyneuropathy families, in some of the families, half of the kids didn't develop the disease. And it turns out that when she sequenced those individuals, they're compound heterozygotes. So they carry VAL30 MET, the disease-associated mutation that typically has a high penetrance for polyneuropathy, but they also have 3119 MET mutation on their other allele. So their tetramers are comprised of both Val30 MET and 3119 MET subunits. And when Per Hammerstrom was a postdoc in my lab, he translated Teresa's amazing genetic observation into a biochemical understanding. And without going through all of the experimental details, the bottom line is that the more 3119 MET subunits in the tetramer, the higher the barrier for the tetramer dissociation to folded monomer is. And so basically what this interallelic transsuppression mechanism does is that it locks the tetramer in its native state and prevents it from dissociating and misfolding, which is linked to pathology. Now, the structural biologists have made it really clear over the last decade that the process of aggregation not only produces amyloid fibrils, but actually produces quite a large, structurally distinct ensemble of aggregates. And we really don't know, despite a lot of effort, which of these aggregates lead to various pathological phenotypes. And so I would submit to this group that strategies that effectively eliminate the process of aggregation are conservative clinical approaches. And in fact, all the drugs that work from my perspective, namely tafamidis and diflunisal and the transthyretin RNA lowering agents, all work by blocking the entire process of protein aggregation. The mechanism by which aggregation leads to the demise of postmitotic tissue, I think, is going to take a long time to figure out. And the reason for that is that it's probably death by multiple cuts, meaning that there's evidence for all of these processes compromising patients' health, shown in the kind of pink shading here. So aberrant signaling, transcriptional interference, activation of inflammation, and it's probably this combination of insults over multiple years that ultimately leads to the dysfunction and loss of postmitotic tissue, and hence these cardiomyopathies and polyneuropathies. So several forms of transthyretin circulate. The one that leads to pathology is the form that doesn't have any ligands associated with it, the one shown in the red box here. So transthyretin is comprised of 4 subunits, each having a predominantly beta sheet conformation. So owing to Teresa's genetic insights, we thought it would be really important to understand the detailed mechanism by which transthyretin aggregates. So first, let's start on the top left. The cells basically don't recognize these mutant proteins as being problematic in the vast majority of cases. Thus, the mutants are secreted at wild-type-like levels. The rate determining step for aggregation is dissociation of the transthyretin tetramer. Once the tetramer dissociates to monomer, in most extracellular scenarios, it just snaps back to the tetramer. But in pathology, apparently what happens, for reasons that we still don't fully appreciate, is that there's a higher concentration of misfolded monomer. And once the transthyretin misfolded monomer forms, it very efficiently aggregates into a spectrum of structures, some of which are shown on the bottom right. So the main take home from this slide is that the rate limiting step for transthyretin aggregation is tetramer dissociation. And when Ted Foss was a graduate student in my lab, he figured out that the mechanism by which the transthyretin tetramer comes apart is about this interface that I'm highlighting here with a laser pointer. This so-called dimer-dimer interface is where thyroid hormone binds in transthyretin. Now, it turns out that in humans in blood, 99% of the thyroid hormone binding sites in transthyretin are unoccupied. So since the weak link in the tetramer is this thyroid hormone binding site, what we decided to do was to fashion ligands that bind to these sites, and in so doing, stabilize the tetramer through small molecule binding and prevent the entire process of protein aggregation from occurring. And the idea would be that that would be a conservative approach, as it doesn't make assumptions about what the toxic structure or structures are. So a way to think about this, if you're more molecular, is that, you know, the idea is that by tafamidis or kinetic stabilizer binding to the tetramer, you increase the barrier required for dissociation, which is the rate limiting step for aggregation. And so if you occupy both of the transthyretin binding sites with small molecules, the activation barrier becomes insurmountable in circulating human blood at 37 degrees. And so basically you lock the tetramer in its functional form, and you make the barrier for dissociation and misfolding insurmountable because of the drug bound, because the drug binds. So this is one of Matt Mauer's quite famous patients, and early on, we titrated in tafamidis in 20 milligram increments. He was a wild type cardiomyopathy patient. And what you can see basically is that the tetramer stops dissociating entirely at the 60 milligram dose of tafamidis. So this was a different formulation, I want to emphasize, though, than what Pfizer is selling now at 60 milligrams. Now, the other important thing to point out is that we still haven't seen the difference between the stabilization afforded by 20 milligrams versus 60 milligrams from Pfizer. And there's a preponderance of evidence now that the 20 milligram dose is sufficient to stop the progression of polyneuropathy in 2/3 of the patients. So it'll be really interesting to see the entire data set comparing these two doses of tafamidis. Now, I don't want to go through any of the clinical trial data on polyneuropathy. It's all published, other than to emphasize one very important point. And that is, as far as we could tell, those individuals that started on tafamidis and those individuals who started on placebo in the 18-month treatment period were demographically identical. And many people have looked at this very carefully. The take home is that those people who started out on tafamidis, 70% of them were responders. If you simply wait 18 months before you start tafamidis treatment, now only less than 50% of the population responds to tafamidis. So really clear evidence that early treatment is really critical to get a maximal clinical response. So, you know, this is one of those slides that after 30 years of effort really made me very emotional. And so this is the collective experience of the Portuguese, especially Teresa Calejo's lab, showing that in a Kaplan-Meier based analysis, the effectiveness of tafamidis versus liver transplant mediated gene therapy. So since the liver secretes most of transthyretin, you can swap out the mutant wild type liver for a wild type TTR liver. And that clearly works relative to not treating the patients. Now, this isn't a perfect comparison because all these individuals are different, but it really is clear that tafamidis is quite effective at the 20 milligram dose in ameliorating polyneuropathy. However, okay, only 2/3 of the patients benefit. The patients in red are truly non-responders. They look like they're not on tafamidis, but in fact, we've done very careful analyses. We can't show a difference between the extent of stabilization in the non-responders and the responders. The drug concentrations are comparable. So there's something special about this group. And in fact, Ionis and Alnylam see the same thing with their messenger RNA lowering agents. Only 2/3 of the patients respond. So it's really important for all of us to figure out what's going on in these patients. Now, the most likely thing is that aggregation is the initial insult. And in the 2/3 of patients who respond, that's the main insult. But maybe in a third, inflammation starts early and becomes a prominent driver. And so if you remove the proteinopathy insult, these patients keep progressing. That's a possible hypothesis. So, you know, early diagnosis is really, really important in these diseases, and it's something that, you know, we're really focused on these days. Now, one of the things that we've done is to make peptide probes that integrate into the aggregates found in patient plasma. And I don't want to go through how these peptide probes work. They probably integrate into defect sites in the aggregates. What I want you to think about, though, is sort of the take-home message. So in polyneuropathy patients or individuals who have a mixed phenotype, polyneuropathy and cardiomyopathy, we can detect quite substantial quantities of non-native transthyretin aggregates circulating. But interestingly, on the right-hand side, you can see individuals with a primary cardiomyopathy phenotype. And basically, we can't detect any non-native TTR circulating. And when Yvonne was a postdoc in my lab, Yvonne Eisel, she also looked at this with native gels and other technologies, and we just don't see non-native TTR in the cardiomyopathy patients. Now, this is also data from Yvonne in vitro showing that transthyretin makes these quite regular structures under physiological conditions, albeit in a sequence where you get predominantly monomer. These are not amyloid fibrils, but something that looks perhaps like a building block of amyloid, although these, at least in the time frame of a year or so, don't convert to amyloid. So again, these may or may not be what are circulating, but you know, it's at least a candidate. So this is the data from the cardiomyopathy Pfizer trial at either 20 or 80 milligrams of tafamidis. And this is the combined data. And you can see that there's a benefit in mortality. But again, what I want to point out is that if the patients are New York Heart Association class 1, 65% of them had a reduction. It exhibited a reduction in the risk of death. But if you progress to class 2, then the effectiveness of tafamidis is significantly diminished with regard to reduction in the risk of death. So again, really important to diagnose transthyretin cardiomyopathy as early as possible and treat the patients as early as possible. And I'm confident that we'll hear a lot more on this subject. Now, I want to end with the idea that we never saw much regarding dementia, focal neurologic episodes, and cerebral vascular bleeding in the transthyretin amyloid patients because they didn't live long enough. But people who were treated effectively by liver transplantation after about a decade developed central nervous system pathology featuring all those phenotypes. Moreover, even earlier, they developed eye pathology and ultimately glaucoma that's not treated by the typical glaucoma drugs effectively because, in fact, the amyloid fibrils and other aggregates block the drainage canals and that causes buildup in pressure. So I hope what I've done today, efficiently, time-wise at least, is to draw the analogy between the mechanism of tafamidis and the mechanism of interallelic transsuppression that Teresa Callejo discovered, and cover some of the data for the clinical trial results, especially focusing on what we know and what we don't know. And I think the combination of the genetic and pharmacologic evidence supports the amyloid hypothesis very strongly. The notion that the process of transthyretin aggregation causes polyneuropathy. Now, what I'm embarrassed to not be able to tell you at the end is, is it the amyloid fibrils that are causing these diseases? Now, the truth is that none of the companies that collectively have spent well in excess of several $billion doing these clinical trials have wanted to measure amyloid load. But what we can say is that with some confidence, although we really need to do quantitative studies, is that it really doesn't look like the patients who respond clear their amyloid any faster than the patients who don't respond. So while there's no question that amyloid isn't good, maybe it's not the main driver, and maybe that's why these drugs work, as opposed to all of the antibody trials that have been now completed where the antibodies selectively clear amyloid fibrils. None of those trials have read out positively from a clinical perspective. So I'll stop there, and we can have some discussion. A lot of people have contributed to this. This is just a few of them. If I put everybody on here, you wouldn't be able to read the names. So thank you very much.
So, Jeff, thank you. So this is Ed Miller. So thank you so much. That was a great talk, and it's really a pleasure to hear all those insightful aspects of the disease pathogenesis. We have a number of questions from the audience. I wanted to ask one question of my own first. And given your historical perspective on TTR amyloid, what are your priorities for the next 5 or 10 years for basic investigations in amyloid biology?
Yeah, so, my lab's very interested in why wild-type transthyretin aggregates in humans. We're really interested in understanding how the process of aggregation causes the demise of postmitotic tissue. And we're putting a lot of effort into proteomics in patient plasma and related approaches to try to come up with biomarkers that signal early disease pathology.
Thanks. So questions from the audience. Does tafamidis have any effect on RA-associated tetramer that has previously been aggregated in tissue?
Yeah, that's a really good question, okay? In principle, it should, meaning that, one of the bugaboos in both light chain amyloidosis and transthyretin is one of the reasons that amyloid could be so bad is that if the misfolded monomers and oligomers come off of the fibrils, and if that's the toxic material, that stuff that can diffuse, then amyloid is the pool, if you will, of toxicity. And so to answer your question, in principle, small molecules that bind to the native state should increase the concentration of the native state away from non-native TTR. That may contribute, but we think it probably does, but we don't have strong evidence for that.
Thanks. One last question before we go to the next speaker from the audience. How much concentration changes of TTR forms are present, different between the disease state and the healthy state? What are the stoichiometric differences in the TTR native versus non-native states?
Yeah, so the evidence suggests that in polyneuropathy patients, there is probably almost as much non-native TTR circulating as native. We don't see that in the cardiomyopathy case. And when you treat polyneuropathy patients with 20 milligrams of tafamidis, you get about an 80% reduction in non-native TTR in the circulation.
Thanks so much. That was amazing. I'm really happy that we were able to listen to that perspective.
Thank you so much for participating. I should have said thank you so much for the opportunity to participate. My brain's not working so much this morning.
Sarah, are you introducing Dr. Bukhari? Yeah.
Yeah, as I had introduced Dr. Bukhari before, he is currently doing a fellowship under the supervision of Dr. Prem Soman at the University of Pittsburgh Medical Center. So we'll look forward to what he has to offer us today.
Thank you so much. Hello, everyone. Thank you for the opportunity for allowing me to present my research from our lab. As Dr. Cuddy was mentioning, my name is Syed Bukhari. I'm cardiac amyloidosis fellow working under the mentorship of Dr. Prem Soman. And this is my first year of the 2-year dedicated cardiac amyloidosis fellowship. So just briefly about an overview of our amyloidosis center. This is a recently established center, which was established in 2018, and we have robust clinical and research operations. The center of our clinical operation is the multidisciplinary clinics. We also have robust imaging. We are also enrolled in different trials, and we also have patient support groups. With regards to research operations, we are very fortunate to have Yvonne Eisel from Dr. Kelly's lab, who has done a lot of work in TTR amyloidosis and is spearheading our basic translational research operations. We also have biobanking registry. We have a PYP registry as well. So just an overview of the current clinical projects we are working on. So we are working on the imaging approaches in ATTR amyloidosis. We are specifically focusing on atrial fibrillation in ATTR amyloidosis in terms of its prevalence, the stroke risk, and the mechanisms involved. And I'm going to come back to it in a bit because this would be our presentation for today. And we are also working on systolic dysfunction in ATTR amyloidosis and its mechanisms. So this is my research for topic for today. Wild-type transthyretin cardiac amyloidosis predicts thromboembolic risk in atrial fibrillation. So just a brief introduction. Cardiac amyloidosis is mainly of 2 types dependent on the underlying pathophysiological substrate. It's ATTR or it's AL, predominantly, as I said. ATTR is further divided into 2 types depending on the TTR gene mutation. If there is no gene mutation, it is called wild-type ATTR. And if there is presence of gene mutation, we call it hereditary or variant ATTR. And the advent of pyrophosphate scan has actually transformed this field of ATTR amyloidosis and has unmasked a high community prevalence. And I'm just going to give you a brief the slides to show how a pyrophosphate scan looks like, and I'm sure you all would be aware about that. So pyrophosphate scan, in order to diagnose transthyretin amyloidosis, we need a pyrophosphate scan in conjunction with the serum studies to rule out blood dyscrasia and AL amyloidosis. So on the top left is the positive pyrophosphate scan. As you can see, there is avid uptake in the myocardium of the tracer. And you can see this is the planar image, and then the same you can see on the SPECT, which shows that there is diffuse uptake of the tracer. On the bottom left is the planar image, which is showing that there is no uptake of the myocardial of the tracer in the myocardium, and same is depicted on the SPECT. So in our lab, we do both. We do a planar image and SPECT image, and I'm going to tell you why it's important. Most of the times, if the visual grade is 3, this is definitive of transthyretin amyloidosis in the absence of blood dyscrasia. And if it's the visual score, or we call it Perugini score, is 0, This is also pretty much definitive that there is no TTR amyloid underneath. However, under certain circumstances, especially what we've seen in our lab, is if the visual score is 1 or sometimes or occasionally 2, this could be in the setting of blood pool as well, as you can see in this case. So this is a planar image, 1R, and you can see the calculated heart to contralateral ratio in this patient was actually 1.5. So you can see the blood pool in the SPECT in 1R. However, once you repeat after 3 hours in both planar and SPECT image, that blood pool tends to go away, and you can easily see that there is no myocardial uptake in this patient. So that's why, in order to make the diagnosis, we tend to use SPECT as the ultimate imaging. So just a brief introduction. Wild-type ATTR is associated with atrial fibrillation. Atrial infiltration with amyloid causes severe electrical mechanical dissociation, which may predispose to higher risk of thromboembolism. However, there is sparse data on exact prevalence of atrial fibrillation and the associated thrombotic risk in wild-type ATTR. So the objective of our study was to determine the prevalence of AF and the incidence of thromboembolism in the form of stroke, transient ischemic attack, or peripheral embolization in patients who had wild-type ATTR and were enrolled in our prospective registry. So in terms of the methodology, we took all the patients who were referred for PYP scan from June 2015 to 2019. And based on the pyrophosphate scan results, we divided them into 2 arms, a wild-type ATTR and non-ATTR. A wild-type ATTR was defined as, according to the guidelines, with a PYP positive, normal serum studies, and no TTR gene mutation. And the positive PYP scan was defined as a visual score of grade 2 or more and diffuse uptake on the SPECT. So once we were able to know which of the 2 labels, which were of the 2 arms the patients were in, the next step was to look into the prevalence of atrial fibrillation in both these arms. And by doing so, we were actually going to answer our first objective, which was to look at the prevalence of atrial fibrillation in wild-type ATTR. Importantly, the atrial fibrillation diagnosis was ascertained from the medical records, and we did not use a Holter monitor, which was a limitation of our study. So then after knowing the atrial fibrillation, so we took all the patients who had atrial fibrillation and wild-type ATTR, and we labeled them as AF ATTR group. And all the patients who had atrial fibrillation and were non-ATTR, we labeled them as AF control group. And we excluded all the patients who did not have atrial fibrillation from the study. And these were the 2 groups that we eventually compared for the incidence of thromboembolism. And we used a multivariable logistic regression analysis in our statistics to predict the independent association of variables with thromboembolism. So of the 277 patients that underwent PYP scan, 28% had wild-type ATTR. And 88% of patients in wild-type ATTR had atrial fibrillation, as compared to only 39% of the patients who did not have ATTR. And this was statistically significant. In terms of the baseline demographic and clinical characteristics, so AF ATTR group were mostly men. They were mostly Caucasians, and they had more systemic congestion, which was evidenced by elevated JVP and pedal edema. On the other hand, the AF control group, they had higher serum creatinine, and they had a higher prevalence of coronary artery disease. One very interesting thing was the AF ATTR group had a lower CHA2DS2-VASc score compared to AF control group. And the significance of this, I'm going to tell you in a bit, once we come to our outcomes. In terms of the echocardiographic features, AF ATTR group, as we could have imagined, had a thicker interventricular septum, they had thicker posterior wall diameter, and they had abnormal global longitudinal strain compared to AF control group. While on the other hand, AF control group had interestingly had higher left atrial volume index, and they had higher pulmonary artery systolic pressure. In terms of the management of AFib, there was no difference in terms of, as far as anticoagulation was concerned, whether they were on newer oral agents or they were on warfarin. There was only one difference, which was in terms of cardioversions. And AF-ATTR group had more people with multiple cardioversions compared to AF control group. So in terms of the incidence of thromboembolism, which was the outcome of our study, so we saw that 25 patients amongst AF-ATTR group had a thromboembolism compared to only 15% in the AF control group. And this was over a mean follow-up period of 43 months. And as you can see that these patients who had with ATTR, they had lower CHA2DS2-VASc score. And despite having lower CHA2DS2-VASc score compared to AF control group, they had a higher incidence of thromboembolism. And this is just the table to show the thromboembolic events in terms of stroke, TIA, and peripheral embolization. And as you can see, there was no difference in terms of all-cause death between the two groups. So in terms of the results, the AF-ATTR was associated with increased risk of thromboembolism compared to AF control group. And on multivariable logistic regression analysis, adjusting for CHA2DS2-VASc, left atrial volume index, and oral anticoagulation use, wild-type ATTR was an independent predictor of thromboembolism. So what we concluded from our study was amongst patients referred for PYP scintigraphy, in our study, 88% of wild-type ATTR patients had atrial fibrillation. And we also found out that wild-type ATTR is a predictor of thromboembolism independent of CHA2DS2-VASc score, oral anticoagulation use, or left atrial volume. And we think that these findings may have important implications in terms of anticoagulation in these patients. So as with any other study, we had certain limitations. This was a single center study. There's a possibility of referral bias in terms of PYP imaging. And as I said earlier, we did not do systematic evaluation for atrial fibrillation. And there was no Holter monitoring that was done in all of our patients. So more importantly, now what we're looking forward is into the mechanistic the mechanistic insight into why these people tend to have higher thromboembolic events. We have some literature, but that literature, as I mentioned earlier, is scarce. There's more literature on AL amyloidosis rather than ATTR amyloidosis and wild-type ATTR amyloidosis in terms of thromboembolism in these patients. What we're looking forward to is, number one, we're looking into the atrial mechanical dysfunction. So we're looking into it through echo and CMR, and we are still devising protocol for that. So this is just one image of how atriopathy you can see in amyloid patients. So on the left side is the amyloid cardiomyopathy, and you can see that not only their atria are dilated, there's also not so much contraction that you see in these atria as compared to a patient with hypertensive cardiomyopathy, which was the bulk of our patients in our AF control group. So this, we think, would lead us to finding some insight into the mechanistics of thromboembolism. So the other thing we are looking into is the platelet function tests. So we are coordinating with the laboratory of Dr. Shruti, who is part of our Vascular Medical Institute, and we are trying to look into if there is any platelet abnormality in terms of the platelet function that is causing the higher thrombotic events, thromboembolic events in these patients. So this was all my presentation. Thank you, and I would be more than happy to take any questions.
Thanks, Dr. Bukhari. It sounds like a great program that Dr. Soman and you have built there, and this is a very insightful and important clinical study. I was wondering, as we talk about thromboembolism, please, the audience can send any questions through the chat function. I was wondering if you could comment about, mitral valve, transdoppler mitral valve velocities, whether it's E-wave or A-wave velocities that have been shown in smaller series from Mayo Clinic, et cetera, in AL to be predictive of thromboembolic risk. And is that something you guys are also correlating in your analysis?
In terms of our final analysis?
In terms of the overall risk of thromboembolism for the patient.
Yes, so that's what we are also looking into it. So far from our studies, we like from just the echocardiograms that we took at the time of PYP, which we use for our study, we didn't see any significant change. But that's the real reason we are looking into the atrial studies. Like we're looking into the mechanistics to see if we can find this answer in terms of the atrial strain, atrial ejection fraction, and other parameters when we look into the atrial the parameters of the echocardiogram.
I guess given that this is part of Prem's work, and that in many cases with SPECT imaging of PYP, we get a very nice whole heart image that can be gated. Are you guys looking at any automated desynchrony analysis from your PYP scans?
Was that a bait for me to step in that? No, we don't gate our PYP scans generally, but the thought had occurred to me, and I think with all this infiltration, it would be very interesting. We have a few patients who've also had myocardial perfusion scans, and we've looked at desynchrony in those patients. We don't see anything particularly striking. I'll also make a quick comment about your first question, which I think is very insightful, I think the reduced A-wave velocities in these Dopplers give you an indication as to the efficacy of atrial mechanical function. The only thing is some of these patients, the reduction in the A-wave velocity is simply due to a restrictive type of filling and very elevated atrial pressure. So to distinguish the reduction in the A-wave velocity between purely a restrictive filling phenomena versus atrial mechanical dysfunction is a little more challenging, but your point's very, very well taken.
There's a question from the audience. It's asked, you prospectively follow these patients with TTR and AF, correct? If that's the case, were the TTR AF patients not on oral anticoagulation, or are you suggesting that a higher risk of stroke despite being on oral anticoagulation? I guess it's getting to whether there's an independent thromboembolic risk of the TTR diagnosis.
Yeah, so it's both. So these patients were, all of them, like most of them, were anticoagulated, and despite being on anticoagulation, they had thromboembolic event. So one is this thing, and second, itself, like wild type ATTR itself, we find out is an independent predictor, which we saw in our study for thromboembolism. However, the only point is what we were thinking was, so all of these patients had CHA2DS2-VASc score, which made, because of which the decision was made that these patients should be anticoagulated. Unfortunately, we did not have any patient who had a CHA2DS2-VASc of 0 or 1 and had a thromboembolic event, because we did not have any patient. Like most of our patients were above the age of 74, like as a mean. So that's why we cannot make that hardline comment that all of these patients should be anticoagulated. But I think what we think is we are probably moving towards like the same, in the same direction as we've moved in terms of the hypertrophic cardiomyopathy, that maybe all of these patients, once they're diagnosed, may need to be anticoagulated, regardless of the CHA2DS2-VASc score.
Thank you. There's another question. I think we're opening up questions to the entire panel, and one from Dr. Sadeghi. What is in common between proteins that contribute to amyloidosis? This might be directed towards Dr. Kelly. are there other ones that share the same characteristics but are not known to be associated with amyloidosis? So it's getting into the protein characteristics that define whether a protein is amyloidogenic or not.
It's a great question, and I'm afraid I don't have a satisfying answer. I mean, what we know is that partial unfolding is really critical for the aggregation of most amyloidogenic proteins, and it requires a short sequence of about 10 amino acids or so that can form a cross-beta sheet or amyloid aggregate. There, of course, are also intrinsically disordered proteins that aggregate, but I think the insight of your question is that what about the rest of the proteome? And the truth is, we really don't know the difference between those proteins that aggregate and those that don't. They seem to be very similar in terms of having these amyloidogenic stretches. So we have a lot to learn here.
If I have a question for the panel with regard to you're speculating about off-target effects of tafamidis, or sorry, some of the unique targets of tafamidis. And as we're exploring these anti-TTR medications, there are these hypotheses about using two types of medications, both RNA inhibitors and the TTR stabilizers. So what's the speculation about the science on the protein degradation or the protein mechanisms of using two agents directed to reducing TTR burden?
I think, I guess my perspective is that mechanistically, sort of the overarching view is that both of these categories of medications, kinetic stabilizers and TTR lowering agents, stop the process of aggregation, one by depleting TTR, the other by kinetic stabilizer depletion of the type of TTR that can aggregate. Now, do I think that the combination could benefit patients? I think there's a reasonable chance of that, and we should test that without cost considerations, because I think, historically, these things get worked out in the marketplace. If there's a compelling reason to combine these drugs and that it benefits cardiomyopathy or polyneuropathy patients, but still the RNA agents are not yet approved for cardiomyopathy. So I don't know if we could do that study just yet. We certainly could test that concept in polyneuropathy, and in my opinion, that should be done.
Thank you. There's a question to the Soman lab, Dr. Bukhari. Is there a difference in the thromboembolism rate in ATTR versus other causes of DCM with AFib?
Difference in terms of thromboembolism? Yeah.
Difference in the thromboembolism rate in ATTR versus other causes of dilated cardiomyopathy with atrial fibrillation.
Yeah, so they had higher rates as well of thromboembolism, the patients with amyloid, with ATTR amyloid. But we didn't do this on AL. It was wild type ATTR population, which had higher rates of thromboembolism.
Okay.
Well, we haven't also formally compared it with other forms of cardiomyopathy. The population was PYP positive, PYP negative.
Yeah.
A question from Dr. Darbala. Dr. Kelly, could the 30% non-responsive to tafamidis or other agents be related to high burden of amyloid fiber at the time of study enrollment? How can we identify non-responders? I think you mentioned the idea of in passing about looking at the amyloid protein burden. Is that what we're going to be? Is that what we should be focused on as imagers, identifying the amyloid burden?
I think my sense is quantifying that before treatment and time dependently after the commencement of treatment is going to be really important. At this point, I don't think there's any evidence that the amyloid burden at the beginning of treatment distinguishes responders and non-responders. Ironically, for reasons that we don't fully appreciate, you can get a pretty high confidence, at least in polyneuropathy, who's going to respond or not respond based on their native TTR concentrations. When they're really low, those individuals are less likely to be responders. So we have a lot to learn, I think, and quantifying the amyloid load and its reduction upon treatment needs to be done desperately.
Yeah, well, I think we all agree on that. Thank you. One more question for Dr. Soman. I know he has a question for himself. To Dr. Soman, have you noticed differences in the drugs or drug doses required for rate control between your two groups of subjects?
That is a great question. I don't have the answer to that. We have not formally looked at it. But as Syed showed, more people in the ATTR AF group had to be cardioverted out of atrial fibrillation and more frequently. So I think that gives us some sort of indirect evidence that these people are more resistant to medical therapy, but that's just speculative. I don't have a formal answer to that.
Great, Prem, and then you had a question yourself.
Yes, I just wanted to firstly say to Dr. Kelly, Jeff, that it was so amazing to listen to this 3 or 4 decades of phenomenal work that elucidated the pathogenesis and the pathophysiology and then resulted in sort of a dramatic therapy that was successfully implemented. Jeff, my question is, I'm sure you're aware of the associations that have been shown between these stabilizing mutations, and there seems to be some hint in observational studies that it may be in some way associated to longevity, particularly related to a lower incidence of vascular pathology. So my question is, do we really know what the function of the TTR protein in the human is? I mean, it doesn't seem to be the major carrier of thyroxine. It is the major carrier of vitamin A, but beyond that, do you think it does something that we don't know yet?
I'm really sorry. I lost internet connection right before you were about to ask your question.
Well, it's 12 o'clock, Ed. So I think I'll give Jeff a call after that.
Great.
Is that good?
Great.
And let us know what the answer is, Prem. When you
I can ask the question if there is time. I'd be happy to do it. Yeah.
We got 1 minute. We have, according to Mike.
Okay.
Keep
Jeff,
going.
I was referring to some of the observational data showing an association between the stabilizing mutations and longevity, particularly with relation to some protection from vascular events. And my question was, we know the TTR molecule is not the primary carrier of thyroxine. We know it carries vitamin A, but do you think that there is some functionality in the human of the TTR molecule that we have not understood yet?
I'm convinced that there's another function for transthyretin that we don't know. Regarding the cerebrovascular and risk, it's the data for the extension of lifespan are really interesting, and it seems to be related to cerebrovascular bleeding risk in stroke. And it begs the question about, you know, if you could diminish, well, I guess it begs the question of how common is transthyretin aggregation in the brain in the aged population, even in those individuals that don't have stark cardiomyopathy. We need to investigate that.
Thank you.
Okay, well, yeah, this has been a fascinating hour of discussion from both speakers and the panelists. I actually have a lot more questions, so I might even email Dr. Kelly myself as well with some of them. But I would like to direct people to the ASNC website for kind of resources there. There's a lot about cardiac amyloidosis imaging, PYP scans, the pitfalls. There's also a consensus paper published last year that addresses many aspects, all the aspects really of imaging of cardiac amyloidosis and transthyretin cardiac amyloidosis. And also I'd ask you to fill out our survey. And please tune in again next week when we address cardiovascular inflammation.